Our presenter today is Dr. Barbara Kostick. Dr. Kostick completed her undergraduate work at Arizona State University. She graduated from medical school at the University of Colorado School of Medicine. Then she did her internship and residency at Hennepin County General Hospital. Dr. Kostick was the first woman elected president of the Washington Medical Staff in 1988. In 2000, she was elected president of the California Academy of Family Physicians. Dr. Kostick is board certified in family medicine and a fellow of the American Academy of Family Physicians. She serves on the National Task Force and commissions on many public health issues. She currently teaches medical students from the University of California School of Medicine. Dr. Kostick is the medical director of community health services at Washington Hospital. And you can see Dr. Kostick hosting Voices in Health and Your Concerns in Health on Washington Hospital's InHealth Channel 78.
I really want to thank you for coming. This is going to be a difficult talk to go through because it's not just stand up and exercise or eat the right foods, but what we're going to do is evaluate the new guidelines that have come out for screening tests and figure out what a screening test is and then what it means to me as an individual. So look at this from an old joke about an Army lieutenant. And we can make the Army lieutenant the government if we want to. And he takes you to a site, and the site is beautiful. It has trees and lakes and a beautiful sky, and the grass is growing. And the lieutenant says, "Look, isn't this wonderful? We've got everything we need." And the sergeant, or the doctors in this case, say, "That's right, Lieutenant. However, where's our tent?" Yes, so the site is nice, but where's the tent? Where's the medical home? And that's the end of that joke. But I was thinking about a tagline for that, and the tagline would be when the private walks up and says, "Gunny," the sergeant, "where's my bed?" You know, what are the patients going to do? What is going to happen to us? And so this is what we're going to do today, is go over some of the things on how they came to that conclusion that all we really needed was a beautiful site. We really don't need a tent or a bed. So let's talk about what the principles are of a screening test. And this is what people look at when they develop a screening test. Well, what's being screened? They look at a condition that has a large burden suffering. So they don't look at screening tests for things that have a small amount of disease. They have to look at big issues. And then they have to look at what does the condition demonstrate the effectiveness of improving. If you have a condition and a lot of people have it, but there's no treatment for it, then they feel there's no reason to screen for it. So if we can't fix it, we're not going to screen for it. And these are the principles that the government or that the national organizations that develop guidelines look at. And then they want to do, what I say is screening for the disease does not always prevent the disease. That's for you to know. You know, when we screen for a disease, we can be screening for it in early stages, and we're hoping that by cutting the morbidity or finding something earlier, that we have a better chance of curing it. But remember, the gold standard on all of these tests is that we do no harm and that we protect the patient. And so the guidelines coming out nowadays have looked at the data and have felt that some of the guidelines that we followed did more harm to the patient than following the new present guidelines. So keep that in mind. Instead of getting mad at them, these are the rules that they have to follow. And then the function. What is the function of preventive services? Well, there's several. There's primary prevention. That means do the service so that you don't get the disease. Then there's secondary prevention. You might have the disease, but you don't know you have it. Now, give me a test that's secondary prevention. Come on, women. No. Yeah, mammograms, mammography, right? Because you're not screening to prevent the disease. You're screening to find it early. And then the third one is tertiary prevention, where you have the condition, but you want to keep it from getting worse. And a thing of that would be like a PET scan if you have breast cancer to see if you have metastatic breast cancer and how to treat it. Now, what about how do we do this? Well, the starting point would be your preventive health visit. That's where you come to see me, us primary care doctors, or your internist, or your OB-GYN, or pediatrician. And at the preventive exam, what we look at, first we screen you through the history. So even just taking a history from you helps us figure out what kind of category to put you in, what further screening we need to do. So all those forms that you fill out do make a difference. I want to, just as a side point on that, we have to take this history over and over again, and you guys probably get tired of answering the same questions over and over again. So my recommendation is you take that screening exam from your doctor's office and you put it on your computer and you put your answers on your computer, and then you just update it and reprint it out every year. So that you don't, and I love it because then I don't have to figure out, well, I had my tonsils out when I was 5 or was that 8? You've put it down. Or when was your last tetanus shot? If you put it down that, oh yes, it was when I broke my ankle and wrecked the skin, they gave it to me in the emergency room in 2004. It's there and it's captured. So just a little hint. So how we screen of course for tobacco, for alcohol and drug use, all these things that can limit your life. We ask you about your diet. We ask you about your exercise, how much you exercise. Are you making that 50 minutes 5 days a week like Vicki talked about? Are you eating a good healthy diet with enough vegetables and fruits in it? And it's amazing when you go into detail on people's diets, especially teenagers. They eat a prepared waffle for breakfast. I'll try not to use brand names. And then then they go and have a roll, and they'll maybe drink some milk at lunch, but there's no fresh vegetables or an occasional apple is their fresh fruit. They just don't even think about it. And then we look at family history, because what I think is that you have to look at what your parents got, because that's what you're going to be sensitive to. So if you have a parent who's diabetic, or you have a parent who died, of heart disease, well, we got to pay more attention to those things when we do your preventive health exam. And we also have adoptive kids that don't know, and we have to pay attention to that too. And then we want to know about the focus screening for depression. This is a huge area that primary care, we doctors who do these exams, are being talked about all the time, that we need to screen for depression. Well, how do you screen for depression? Any ideas? Well, how do people look? You've seen people who look depressed, right? Never happy. Yeah, they look tired. And in fact, when I interview someone who's really depressed, I'm tired at the end of the interview. I can feel that wave of depression from them. But there's questions you can ask too. How do you sleep? Are you getting enough sleep? Can you sleep through the night? People who are depressed can't sleep through the night. Lots of times they can fall asleep, but then they wake up early and can't get back to sleep. Are they happy? Is there any happiness in their life? Do they feel happy? So there's certain screening questions that we ask everyone about it nowadays. And it actually, for Medicare, it's one of the components of the general wellness exam for anyone that's welcome to Medicare physical, which you must have within 6 months of signing up for Medicare. So remember that and get it scheduled if you're appropriate. And then, after we do the history, we do the physical exam. And what are we screening for in the physical exam? Well, look, we're looking for blood pressure and weight. We're looking at your skin, looking for skin cancers or signs of not using enough sunscreen, so you're getting little age spots and freckles and stuff. We look at the other organ systems like the heart and the liver and the kidneys. And so then what happens? Well, one of the things I think that's really important in part of the comprehensive exam is your immunization update. I was going to make this all flighty, come in and stuff, but I thought you might as well see the whole thing so you can take it in. Everyone needs a tetanus shot every 10 years. A couple of years ago, there was a big scare about whooping cough. Remember, they had whooping cough in the schools and the middle-aged kids. And they figured out that our immunity to whooping cough wears out. So when you talk about a Tdap, that is a tetanus. T stands for tetanus. D stands for, yay! D stands for diphtheria. Okay, here's what does AP stand for? Yeah, and pertussis, good. It actually stands for acellular pertussis, which in the old days when I got these shots as a kid, they didn't have that. And so they used to have huge big fevers and kids would get seizures because it wasn't. Now they use the acellular pertussis, and we don't get the bad effects on immunizations like we used to in kids. So acellular pertussis. So even if you had a tetanus shot for an injury, say in the last couple of years, you need to make sure that it was tetanus with the whooping cough. Because if you're around small children, if you have a daughter who is pregnant or daughter-in-law who is pregnant, if you have a sister who is pregnant, you should make sure that you have your whooping cough shot so that you do not expose this unborn child, soon-to-be born child, to whooping cough. And then postpartum, and this is why we put it in for women of all childbearing age, have to make sure they're up to date. We have to have women who are postpartum, relatives, grandparents. So check it out if you're in that category. It's really, really important. In school-age kids, they now have to have this shot before they get into middle school. That's the California rule. So usually anyone in middle school is immunized, and that immunization should last at least 10 years. So right when they get pregnant, we don't know if it's going to last or not, do we? 21, 11 to 21. And now there's another new vaccine out for women between the ages of 11 to 26, and that's the human papillovirus vaccine. And that helps prevent cervical cancer, and also, and I'm sure Dr. Sharma is going to be talking about it too, it also helps prevent something like 25% of head and neck and throat cancers are caused by human papillovirus also. So yeah, so it's really an excellent vaccine. It's given to kids from age 11 up. I have a difficult time giving it to some 11-year-olds, so we can do it at age 12 and up. But definitely, if you have a child or a sister or someone that's in, say, that 18, 19, 20-year-old group that didn't get in the school screening stage, because this has just come out, be sure to make sure that she goes down and gets her HPV shots. It's a series of 3 shots. Well, that's a very good question, because this is Women's Health. I was going to do that, but I'll give you a side. It just came out from the CDC that boys could have the vaccine also, because it prevents the venereal warts in boys. And the other thing is though, if it's associated with other tumors of the head and neck, I would think, but that's not one of the indications they put on. It's just an association. So, yeah, so if you have a child, you know, a boy, the criteria is the same, 11 to 26. And there's also for children, there's the meningitis shot for children starting at age 11 also. Now, what about the Pneumovax? The Pneumovax has gotten big press nowadays. It's automatic for any woman turning age 65 for Medicare, paid for by Medicare. It's also recommended for women if they have a condition that helps them not fight infections, such as if they have asthma, if they have diabetes, they should get the pneumococcal vaccine earlier. Don't wait till they're 65. 65, you're supposed to get that 1 shot. You're supposed to not need a booster. It's gone back and forth on boosters, no boosters. Frankly, I give my 80-year-olds another shot. Influenza every year after age 50. Influenza shot does not prevent disease, but it does prove that it shortens the amount of time that you have the illness. So, and I think especially if you have a comorbidity, asthma, diabetes, something like that, immunocompromised, you definitely should have your influenza vaccine. There is an influenza mist that's recommended for people under the age of 45. And that one also is wonderful because, one, you don't have to give a shot. But the other reason is that it actually develops immunity in the mucous membranes of the throat and the mouth, and that's an IgA immunity, whereas the influenza shot has to go into the bloodstream to get the IgG immunity. So I really love this one for children. I just think the children should all, you can't give it to asthmatics, but any other child should probably look at the flu mist instead of the shot.
Is there a reason why after age 50 rather than before?
The reason is that they think that 50 is old now. Because the studies were done that way. That's why.
Okay.
Yeah.
They found that people over age 50 are more inclined to be affected by it.
I think people over age 50, you get people who have a lot of other diseases, more so than in the younger age group. However, where they found where the influenza virus hides is in the preschool age group. And those are the ones that really need the immunity so the rest of us don't get sick. Because, you know, the preschool, the parents take their kids to preschool, the kid comes home with the disease, the parents go to the workplace and spread the virus touching phones and coughing.
Well, I'm thinking of in terms of the person catching a public transit system and enclosed in a
That's right.
confined area that no matter what age you are, you could possibly pick it up easily that way.
That's right. And you bring up a very good point about what the screening test says. It says after age 50, but the recommendation is that every person should get a flu shot. Everyone. And again, this is the disconnect between what a screening test is and what's best practices. And so now the United States Preventive Services Task Force, write that down, circle it in your handout, and go to their website, because they are the ones that determine the recommendations for what insurance companies pick up and what government will pay for in your insurance package. And so here are their recommendations for women under age 50 that show good evidence. And now it's 2 seconds on evidence. Evidence is now being rated based on A is the highest form, where it's been random trials and double blind, so some get it, some don't know, and then crossing over. Then there's fair evidence, which is a B rating, and that is usually observational. Well, I think in my practice it really is better if we do this. And so everyone pools their observational data, and if it looks like just from observation that it's good, then it gets a B rating. And it goes down. And the other rating you're going to see a lot of is the I rating, which means we can't tell and determine it. So screening for bacteria in the urine in women who are pregnant, yes, definitely a good indication, good screening test. We want to prevent preterm labor, and this prevents preterm labor. Screening for breast cancer with a mammogram is not recommended in the under 50. What do you guys feel about that? Because? Oh, but then it's not a screen. This is a woman that has no risk factors. Family history is a risk factor. Okay, so anything? Yes? No? Go ahead.
I think women should. I thought it was just a financial thing. But
Well, actually,
want to do it for
yeah. Well, we're going to go into this in more detail later, but it's nice to come out with these ideas. So keep saying, so I'll know what to talk about when we bring it up again. Pap smear. Now this indication changed in March of 2012. And what's the date? Right now. So we madly scrambled and got you the new recommendations on the form. And yeah, because pap smear, if previously normal, you don't need an annual pap smear. It's every 3 years if you're under age 50.
And if you're over 65, I understand you don't have.
We're going to get to the over 50s. Hold that thought. So, and not everyone needs a pap smear even at every 3 years. They have to have a cervix. You do not need a pap smear if you do not have a cervix. And that has been a big bone of contention for 20 years. Now, what about screening for chlamydia or sexually transmitted diseases? Well, there's very good evidence if a woman is at increased risk. Well, what's increased risk for a sexually transmitted disease? Multiple partners is usually, and no protection, using no protection. And then if you're pregnant and under age 25, there's fair evidence to show that that would be a good indication too, because you don't want to spread the trachoma virus that can cause blindness to the baby. So you screen there too. And our guidelines in most of our exams are girls ages 16 up to age 26 should be routinely screened for chlamydia. And we do this now with a urine specimen, not with going in, grabbing some goop and sending it off. But you just send them the urine and they have a DNA probe that's very, very sensitive. Well, what about over 50? Let's talk about heart disease, #1 killer, right? What about aspirin? How many people do you know over age 50 that take aspirin? Do you think they all should be taking aspirin? Neither am I. It's for primary prevention for women ages 50 to 79 where the benefits outweigh the risk. So what are the risks of taking aspirin? GI bleed, skins get thin, they bleed. And there is good evidence of effectiveness if you are at increased risk for heart disease. So that means high cholesterol, diabetes, family history, hypertension, smoker. If you have those kinds of risk factors, then you should be on aspirin. But if you don't have those kinds of risk factors, you could probably talk to your doctor and see what you should be doing. And if you don't know your risk factors, then you need to talk to your doctor about what your risk factors are. So now what about breast cancer? They feel that women between the ages of 50 and 75 should be screened biannually. Biannually means every 2 years. Because when they did the meta-analysis, this is a B rating, fair evidence, B rating, that they did meta-analysis, and looking at all the meta-analysis, they found that there was you had much higher risk of having a unnecessary biopsy than developing the cancer. And when we go through the indications that came out, like the American Cancer Society and the other indications, we'll talk about this point more. And then pap smear for cervical cancer every 3 years, up to age 65, and sexually active. And then there's a new one out that says you check for HPV, and it can be every 5 years, and I'll show you the slide on that. And then cardiovascular disease, again, is 50 to 75 years, 55 to 75. Men are supposed to start at 45. They start 10 years earlier. But you have to have moderate to high cardiovascular risk. That means a 10 to 20% risk of having a heart attack in the next 10 years. And you measure this risk based on your blood pressure, your cholesterol, how much you exercise, how healthy you are, do you have diabetes. Now what about colorectal cancer screening? 50 to 75 is when you should start at age 50. And they give you lots of choices. You can have the GWAG, fecal occult blood test. That's where you open up the little card, take some stool, put it on the card. They have an ISO fecal occult blood, which is very, very sensitive for blood in the colon. And so then they say you could have a flex sigmoidoscopy. That's the scoping where it just goes up this far. Or you can have the colonoscopy, which goes up that far. Yeah, and it's good for 10 years if you have no pathology found. If they find a polyp, even if it's not cancerous, they'll see it 5 years then instead of 10. But then you fall out of screening. See, this is for just the screening guideline. And as long as you stay totally normal with nothing to change the screening guideline, then you can do it every 10. But if you have a polyp and it had biopsied, then you will be probably on every 5 to 7. Osteoporosis, bone mineral density screen for women, right? Says we should have it at age 65. Do you know the evidence behind that? None. It was lobbied by Congress. The evidence is if a woman has a fracture, menopausal, she should get her bone density done. And then you have to look at the woman's risk factors. Parents, her mom has osteoporosis, sister has osteoporosis, how many fractures, we go through these things. But everyone should be taking their vitamin D and their calcium. And that means young people too, because young people under the age of 25 are building up their bones. So be sure that they get enough vitamin D and calcium also. Recommendation is probably around 2,000 milligrams of vitamin D now. And I always feel if I take that much vitamin D, I don't have to take as much calcium because it's absorbing every little milligram of calcium I'm taking. Now, what about diabetes screen? Now, when we're screening for diabetes, we're not preventing it, right? We're screening for finding it. And the recommendation isn't a fasting blood sugar on your annual exam. The recommendation is that people who are hypertensive really need to be screened for diabetes because of heart disease. Because if you are hypertensive and you have heart disease, you have a huge risk of a cardiovascular event, and it needs to get taken care of. And then cholesterol every 5 years if it's normal. If your cholesterol is abnormal, you do not fall into this screening category. And then, of course, we're supposed to look at lifestyle-related problems, just like we talked about doing the history and physical exam, looking for obesity, physical activity, alcohol, tobacco, family. And then another thing that's recommended for the over 50 is the injury preventions, because that's how people break their hips. That's how we get someone who is living alone, taking care of themselves, to a nursing home, is from a serious injury. So we have to make sure that people can hear, they can see, and they have good activity. The more active you are, the more healthy you are. And one of the things I see in older people is they sit a lot, and even on computers, they're still sitting, and they don't develop their balance. For us to get good balance, we have balance receptors in our feet. They're called proprioceptors. And by feeling the weight on your feet, what you're seeing tells you how balanced you are and how steady you are on your feet. So my recommendation is that stand up with your eyes closed. See, make your feet work. Send it up to the brain where your balance is. Do that a lot. Do it on one foot. Do it on the other foot. Okay? Get up from the chair without using any arms. You see all these really old people, they get up and they push themselves up out of the chair. By doing that, they are not giving enough weight to their feet to send the message up to their brain where they are. So again, you got to really, really work on your balance, because it makes you healthier. Okay, so here's the cervical cancer guideline. Why are we screening for cervical cancer? Because the screening is used to identify high-grade precancerous lesions. It's not used to identify dysplasia or atypical, all these things that we had about 10 years ago. And to prevent the development of invasive cervical cancer. In the past, when we did these guidelines, we had Bethesda ratings where, this is a slightly atypical pap smear. Any of you guys ever get that slightly atypical pap smear back and have to have it followed or get colposcopy or all that other stuff? Well, they found out that isn't really, doesn't do anything. It doesn't prevent cancer. The thing that prevents cancer is not finding the dysplasia. It's finding not the low grade, but the high grade intraepithelial lesions, SGSIL. So the new recommendation is that you do not need to do a pap smear on someone under age 21. And I can still remember under the old guidelines, I had a patient that was 18 and had this slightly abnormal pap. And we had to pap her every 6 months. We had to do colposcopy because we were going to prevent cancer. And what they found is that our cervix change with time. And we can get into these stages, like from inflammation, it can change your cervical cells for a while, but that isn't the cancer. Cancer is caused by, we talked about it earlier, what's the shot? Cancer of the cervix is caused by HPV. It's not caused by inflammation. So the other reason I really like this guideline is this means a lot of my teenagers who are scared to have a pelvic exam will still get birth control. And I'm in compliance. And they say we do not have to screen women over age 65. I guess we just stop sex at 65. If someone is sexually active with the same partner, I'll let them skate a little bit if they're 65. But if they're 65 and sexually active with a different partner, I still screen them. Or if they think their partner is sexually active with other partners too. So screen women 21 to 65 every 3 years. You did that before, right? Because HPV infection is associated with nearly all cervical cancers. For women in the 30 to 65 year age group, we will add a test onto that pap smear to check them for human papillovirus. And if that test is negative, they only need to be screened every 5 years. Caveat to that, and this is mine, no pap does not mean no pelvic. Just because we don't do the pap smear doesn't mean we really shouldn't just put our little hand in, feel around, feel the ovaries, feel how your bladder is, feel how big the uterus is, see, for other problems as part of your exam. But you do not have to send off the pap smear. And you guys have to start taking very careful dates for your paps, because I attended a insurance thing where they said they're not even going to pay for pap smears if the patient has had a normal pap in the last 3 years because of the recommendations now. So that means you can be stuck with the bill if you don't remember when you had your last pap smear. And it's even if you change insurance plans. The insurance plans all talk to each other. And, anything to, as you said, anything to save them a little money. So this is the recommendation. It's a very, very busy slide. But that is what you will get from the website if you go up to their website. So if anyone's concerned about this recommendation, brand new out, developed, revised March 2012 about the 5-year PAP with HPV testing. So this is what's happening in medicine is we are changing from a bunch of good old boys sitting in a room and deciding what we think is best to the patient to actually looking at meta-analysis and data and figuring out what would be the best strategy. Remember, these are always the screening tests with no risk factors. So you have to always evaluate your risk factors and know your risk factors. So now let's talk about the breast cancer controversy, because I was involved in that. When the United States Task Force indication came out, we were all aghast. Because when they first came out in 2009, they said that the clinical breast exam doesn't do any good. For the woman between the ages of 40 and 50, a clinical breast exam doesn't do any good. A self-exam doesn't do any good, and we do not recommend a mammogram. So tell me, how are we going to find breast cancer in the women aged 40 to 50? Yeah, so we thought maybe they just didn't write the recommendation right, because we couldn't think that they would do that. Just say, no, don't do anything, just let them get breast cancer, and we'll find it at age 50 when we pick up their mammogram. But what happened when this recommendation came out, here is how it was in 2002. In 2002, the recommendation was you start screening at age 40. And it developed reduced benefit. So it only had a B rating, fair, because of a bunch of unnecessary breast biopsies. And then we were finding cancer so early, we didn't know what to do with it. We still are having trouble figuring out what happens. I mean, I see people in my practice that they're found at a very early stage, very early cancer, think it's all fine, and they end up getting metastases and having horrible disease. And we have other people that get a cancer that is over 2 centimeters, with increase, you'd think it'd be more aggressive, and nothing. They have their surgery, they do fine. So we still don't know who we worry about. There's a lot of special stains and things now that they can do to help determine this, and the big guys are working on it. So that's why there was possible overtreatment in these people that had maybe 2 cancerous cells. So in 2009, they recommend against routine screening. And so here is what we had them put in. Because we said, you guys, you can't tell us no self-exam, no clinical exam, and no mammogram. So we said the decisions should be individual. And you got to sit and talk to your doctor and discuss the pros and cons, that it might come out with an unnecessary biopsy, or you can wait. Because when they did the original screening test, the endpoint of their screening recommendations was death. It was not morbidity. It was not our thought that if you find a cancer early, you can get rid of it with less morbidity. You don't have to do as much surgery. You could do a sentinel node. And that isn't what went into the screening criteria that came out in 2009. And so I encourage you all that when you go and talk to your doctor from the 40 to 50 age group, be sure to say these things. Or for your daughter, make sure she stands up and knows it, And so this is the huge big one, where it says that, and you have it in your handout, so you can read it too. But it says 2-year screening for 50 to 74. Oh, at age 75, we all can die of whatever they want, All screening stops at 75. Colonoscopy stops, mammogram stops. Again, I personally think that's individual depending on how healthy the person is. I can see if a person has terminal cancer, you don't have to put me through that too. But there's a lot of very healthy, active people that are now 90. And the gold standard is if you think a person is going to be around with good life for another 10 years, you should screen them so that they continue to have a good life for those 10 years. That's kind of the thing I use when I talk to people. So if you're 75 years old and in good health, you get a mammogram because I think you're going to be around another 10 years. So decision to start is individual, remember, because of the unnecessary biopsies that happened. Current evidence is insufficient, it says, to assess the additional benefits and harms for over 75. They recommend against teaching breast self-exam. This was kind of interesting. I went through the whole thing of teaching everybody how to do breast exams. And we had all these little models that we'd bring out and show them and had a little card they could hang in their shower so you'd remember to do it. And what happened is they found out all these women aged in their 30s would come in with that they felt a lump somewhere. And it turned out that it really wasn't a lump, and they had a lot of really unnecessary surgery because of their anxiety. And so that's really why they did away with the breast self-exam. And then they say, we're not any good either, so clinical exam isn't very good either, but I still feel. And then what about the additional benefits of an MRI versus a mammogram? For a screening person, no risk factors. The screening mammogram is the best one. Be sure it's digital. Be sure the equipment is current. Here at the Washington's Women's Center, both of those things are good. If you have your exams done elsewhere, make sure that the equipment they use is as good and that it is digital so that they can go back and look at it without exposing you to more radiation. MRIs are reserved for people with strong family histories or a lump and a strong family history, and on mammogram it still didn't look good. I'd insist on having an MR. So.
How about an ultrasound?
Ultrasounds are how if the mammogram is abnormal, it's how you evaluate it. But to use an ultrasound as a screening test is not good enough. Okay? Yeah, it is good from a radiation safety viewpoint because it doesn't give you radiation. But it's not a good screening test. And just like they used to have these thermographies where you measure the heat in the breast, that's not a good screening test at all. In fact, it's harmful because it can miss cancers. So what are our other resources? Or as I would say, if you don't like what the experts say, find another expert. Okay, so here's what the American Cancer Society says about breast screening. They recommend yearly mammograms starting at age 40. They're very proactive screening. But these particular guidelines were developed a few years ago, so we'll see what happens over the next year if they change these. And I got these from their website, another good website to go see, acs.org. And the clinical breast exam, they filled every 3 years. When you go in for that every 3-year pap smear, I guess you can have your breast checked too. And then women should know, here's the no breast self-exam, but you should know what your breast looks like. And I just tell people when you're showering and washing, just be sure to wash all the way down and get used to it. They're going to be there a while, hopefully. So what about American Cancer Society's things about colon rectal screening? They say that it's the same thing as the United States Preventive Task Force, the flex screening, the colonoscopy. But they want to even add that you could be screened with the double contrast BE. No, thank you. If you guys have ever had one, no thank you. What they do is they put all the barium in, you evacuate the barium, and then they fill up the colon with air. It's painful, no thank you. And then the CT, the virtual colonoscopy, again, these guidelines are older, and there's a huge push now about radiation safety. And the CT scan is the one that gives you the most radiation. So I personally would not recommend this as a screening test. My personal recommendation is a colonoscopy. You get to sleep, give you a little nummy medicine, as my daughter says, and you go to sleep, you wake up, it's done, they tell you what it was, and you say, fine, thank you. And that's to find the polyps, but then if they want to find the cancer, then they talk about the fecal occult bloods and this immunochemical one, which is, I called it the IFOBT. So I like to do that in between colonoscopy as the IFOBT. But again, if a test is positive, you have to do the colonoscopy anyway. So that's why, again, I push for the screening colonoscopy. And what does ACCS say about cervical cancer? They say it should start at 21, just like the new guidelines. They say women between 21 and 29 should have a PAP every 3. That they should, now they're saying HPV testing should not be used in this age group. It used to be HPV testing was used in this age group and not in the older age groups. But what's happened is they think colon cancer comes out in the 30 to 40-year-old person. And then women between the ages of 30 and 65, just like we said, need the PAP and need the HPV testing, and then they can have it every 5 years. If you're over age 65, they're a little better. They say you can have a PAP. And then if she's had her uterus and her cervix removed, then she doesn't need to have a Pap smear. Remember, guys, if you've had a hysterectomy now, though, if it's endoscopic, laparoscopic with the endoscope, lots of times the doctor will leave in the cervix, and you need to know that because you will still need Pap smears. So be sure, again, know your history. And then even the ones that are vaccinated, the new kids out, should still use the screening recommendations. So they still get Pap smears. But remember, a screening is only a screen. These are my little grandchildren, twin boys. And they didn't know she was pregnant with twins until 20 weeks. Thank you.